Hi there. I'm going to tell you about the population health study, which was Project One from the Schreiber Environmental Health Domain. Jacobs proudly acknowledges Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands upon which each Jacobs office is located and those upon which we operate throughout Australia. We pay our respects to elders past and present. We acknowledge that sovereignty was never ceded and we are committed towards reconciliation. I'm Jenny Wade. I'm a public health specialist and my role on the project was to interpret health data and to develop the monitoring framework. I was supported by a team from Jacobs, including Nino Karishvili, our lead, who developed the study concept, and Gillian Montgomery, who provided the literature review. Colleagues in our Darwin and Brisbane offices provided project management support and contacted local health providers. Here are the objectives of the population health study, which were to define a study area, to collate and interpret health data and establish a health baseline, and to describe an appropriate long-term monitoring plan. By the term population health, we mean the health outcomes of a group of individuals, including the distribution of health outcomes within the group. So we're concerned with the health of populations rather than the health of individuals. Our work was undertaken in four main stages, the first stage being to define the boundary. We needed two study areas and we were helped by NT Health in this regard. The first study area was focused around the specific Beetaloo sub-basin communities, defined as those with residential addresses in Mataranka, Gilkmingen, Larrimar, Daly Waters, Dunmara, Newcastle Waters and Elliot. Our second study area was more regional in scale, based on the Australian Bureau of Statistics Statistical Area 2 regions of Elsey, Catherine and Berkeley. And we needed this study area for the mortality data. So the two study areas were because of differences in the levels at which health data are provided. We undertook a quick literature review just to check for any substantial updates since the literature review which underpinned the 2018 fracking inquiry. We didn't find any substantial new findings and the information we had was aligned with that reported in the fracking inquiry. It should be noted that there are major limitations with a lot of the research in this area of the impact of the oil and gas industry on health. Sometimes the health literature doesn't distinguish between whether it's an outcome associated with an oil refining process or a gas process because they use the term oil and gas in its entirety. And it's difficult to conduct good quality research because it's difficult to separate out other factors, for example, exposure to household chemicals, smoking, diet, lifestyle choices, all of which may be independently associated with the same health outcomes of concern for fracking. Also, the literature is generally, or the largest body of literature comes from the US, in particular Pennsylvania, and there are very different geographical circumstances in Pennsylvania. For example, the population of Pennsylvania is 790 times larger than the population in our Beetaloo sub-basin study area. Also, the area of Pennsylvania is 3.5 times smaller than the Beetaloo sub-basin SA2 study area. So by comparison, Pennsylvania is a lot more populous with a greater population density, and these differences may affect the relevance of findings in the health literature to the local Beetaloo subbasin context. Furthermore, Australia has a tighter regulatory framework around onshore gas extraction than many other countries, including requirements to declare substances used in hydraulic fracturing fluids. So some health outcomes reported in the health literature may relate to substances which are used in the US, but which are not permitted in Australia. The indicators that we looked at were taken from the NT scope for the NT government scope for the population health study, recommendations from the fracking inquiry, findings of the health literature review, and consideration of the local health context. Please note that effects on well-being and mental health are not part of the population health study, but are covered in another project. We had several challenges with our baseline health analysis. We received data from Northern Territory Health, but at the time of completing our report, data had yet to be received from the Sunrise Health Service Aboriginal Corporation due to the timescales associated with obtaining data sharing agreements and approval. Also, because the population is very small in the Beetaloo subbasin, we only have small sample sizes for health outcomes, and small sample sizes are not sufficient to allow statistical significance to be drawn for epidemiological purposes. The health data sources were not designed for this study, and also there are limitations with some of the records. For example, the Elliott Primary Healthcare Clinic, almost 40% of the records did not include a reason for attendance at the clinic or a primary reason. So it makes it difficult to inform incidence or prevalence for health conditions. Since it's a relative, um, so let's look at the population profile. We've got small communities and a young population. Almost 70% of the population is aged under 44 years of age, and 70% of the population comprises Indigenous Australians. Broadly speaking, it appears that diabetes and asthma are the more prevalent health conditions in the area, followed by heart disease. The prevalence of heart disease in the Elliott suburbs and localities does appear high compared to average. It may be skewed by a small population size. In terms of causes of death within the Beetaloo subbasin, cardiovascular disease is the leading cause among the health indicators of our study. Hospital separations refer to any time a patient leaves a hospital, which might be because of death, discharge, signing out against medical advice, or transfer to another health facility. Cardiovascular and respiratory conditions are the leading indicator health conditions for hospital separations in our study area. This graph shows hospitalizations for respiratory conditions. Where there's no data shown on the graph, that indicates that the case numbers were too low to allow a separation rate to be calculated. So we can see that the rate of hospitalizations among females for chronic obstructive pulmonary disease, COPD, is substantially higher than for men. We can also see higher rates among Indigenous people than non-Indigenous people for all three classes of respiratory conditions. But remember that this is a crude rate, and this difference in part reflects the higher proportion of Indigenous people in the population. Nevertheless, it is about 8 to 10 times higher than would be expected, all other things being equal. So that may indicate a health inequality. And we can see that hospital separation rates for COPD and other respiratory conditions is much higher for people aged over 44 years old. And this reflects that increasing age is a risk factor for these conditions. In terms of incidence of other indicator health conditions, we can see relatively high incidence of trich, which is a sexually transmitted infection. Levels of other conditions like Ross River virus are quite small. We found that for some conditions over the 10-year period, cases were too low to allow calculation of incidence, or we might even have had no cases. For the types of cancer most associated with the fracking industry, we had no or very low case incidence. Skin, eyes, and nose irritations were indicator conditions recommended from the fracking inquiry because they are among a range of symptoms commonly associated with irritant substances. However, it's difficult to get a reliable estimate of incidence of these conditions because they are often acute, i.e. short term and mild, and people may not seek formal health care, so they're more likely to self-care or choose over-the-counter treatments. It's likely, therefore, that any data we do have on this is a large underrepresentation of the incidence of these types of condition. So we've developed a monitoring framework for the relevant indicators, but there is a need to refine this further with stakeholder engagement to produce a detailed plan. In terms of recommendations for data collection, it is anticipated that NT Health and Sunrise Health Service Aboriginal Corporation can provide data for most indicators based on primary care centre records and presentations. We also recommend that a community health survey is undertaken to collect data on general health and behaviours. And it may be possible to tie this in with any surveys done to address cultural concerns, mental health and well-being. The benefit of a community health survey is that it may provide data more specific to the study area communities, particularly where people have not accessed formal health services. It would also enable the local community to be involved in the research and benefit from skills and training. Development of a phone app for self-reporting of symptoms would enable real-time data to be received. It would be the most effective means of gathering data on acute mild symptoms. And in the event that higher than expected reporting of symptoms, a response could be triggered to investigate possible causes. Smartphone use is widespread, and therefore this is considered to be a widely accessible format. There may be potential to link with other apps already in use, such as for air pollution incidents. We would also recommend a cohort study design, which would require agreement and cooperation from the community to participate. Our monitoring framework is really a first step, and it will require local support and engagement to develop it into an implementable plan. We have identified some possible stakeholders who could support this process. In particular, it will be important to get the support of Sunrise Health Service. The University of Queensland and Menzies School of Health Research could also bring valuable experience. We anticipate that the monitor indicators may need to be refined to address local concerns, practical considerations such as the ease and cost of data collection, specific human health risk assessments that take account of the chemicals used and offset distances, and any crossover with social, cultural, and mental well-being considerations. The logic model on this slide sets out the, the overall approach. It will be really important to get Indigenous representation so that the plan reflects the interests of local communities. There will be a need for ethics approval for the health survey. In the short term, the monitoring plan should give us improved understanding of the baseline health profile, whilst also improving community awareness of shale gas production and the measures in place to protect human health. In the medium term, we will see trends in health outcomes and have opportunity to respond to changes in health outcomes through targeted interventions. With effective local participation, the community health survey may result in improved job opportunities, as those involved would have training and develop new skills. Ultimately, it is hoped that the monitoring plan will provide a degree of reassurance and trust for local communities where fracking may take place. Thank you.